Hello, everybody, and thank you very much for joining us. With us today, this afternoon, is Dr. Roy Cassiano from Miami. Dr. Cassiano is a very well-known rhinologist, and I think we've seen him in Dubai quite a few times. Dr. Cassiano, can you hear me? Let me just open up your microphone. Sorry.
Yeah, right. Now I can. You had me muted there. How you doing?
Good. How about yourself?
Good. Hello, everyone.
Thank you very much for being with us this afternoon, and everybody's looking forward to your talk.
My pleasure.
So please go ahead. You have the podium.
All right. So I'm going to share the screen with everybody. Are you recording, or you send me the link of the report?
Yeah, absolutely.
Okay.
Yeah, I'm recording.
All right. Thank you. Let me share it with everyone. Hopefully everybody will see it here. Everybody see it?
Looks great. Thank you.
Okay. So it's about frontal sinuses and the access to the frontal sinus. And I kind of titled this From Balloons to Drill Outs to Multi-Port Approaches. And I'll explain that in a minute as to why I say that. But it's pretty much follows the kind of the thought process that we all go through when we approach any sinus disease. We always like to go from the minimal to the more advanced, depending on the situation. Nowadays, we sometimes go straight to the advanced, again, because of certain situations, even in primary cases. And we'll go through a few examples. Here are my disclosures. So just a little bit about the frontal anatomy. As far as what pertains to endoscopic approaches, I think the critical point here is that you really can't be a very good endoscopic frontal sinus surgeon if you're not a good ethmoid sinus surgeon. You have to understand the ethmoid sinuses to navigate up into the frontal recess and then into the frontal infundibulum. So you have to know the trajectory in which you have to go through and all the relative landmarks that guide you there. Even without the use of navigator, you should be able to do this. And you can see that I've divided the ethmoids into 3 columns of cells. One column is, in a sense, if you include the Agarnazi as an ethmoid cell, I guess, you got this column of cells in red, which is the uncinate down below, the Agarnazi, and then the supra-agar cells that may vary in number and extent up into the frontal. And then you got another column of cell behind it running parallel, which is the ethmoid bulla, which is the lowest one right here, and then a bunch of suprabular cells above it with the anterior ethmoid artery lying just midway between this suprabular cell here that's just between the back wall of the frontal infundibulum and the ethmoid artery, and then another suprabular cell just behind the artery. So we always look for those 2 cells up there. And then the last column of cells back here, which really have nothing to do with the frontal, is in blue or purple here, and these are the posterior ethmoids. What's important here is to understand that the frontal recess actually runs posteromedially between the red column of cells and the green column of cells. Okay, towards the insertion, towards the vertical lamella of an insertion of the middle turbinate. Okay, but the actual frontal infundibulum, which is the opening that we all look up to when we do a Draf 2B or 2A, is really above the red column of cells. It's above the supra-agar cells. Okay, because you have to go forwards and then up. So really the anterior ethmoids as we know them, the ethmoid bulla, suprabular cells, have very little to do with the frontal sinus, except that if you're in them and you're going superior and you keep going in the trajectory superiorly in this green column of cells, you're going to go intracranially. You're not going to go into the frontal sinus. So one of the things I teach in the lab early on for residents is when you do frontal sinus surgery endoscopically, try to just navigate along the Agarnazi, then supra-agar, and stay close to these cells as you go up in this direction and leave the suprabular and bular cells intact. So this face here stays intact. So you really get an idea and appreciate how you really don't need to be in the ethmoid sinuses to go into the frontal. Also, the trajectory that you go towards infundibulum here from the frontal recess forwards and superiorly into the infundibulum is really parallel to the lacrimal convexity here. So if you or you're not sure which direction you're going parallel to the lacrimal convexity, and you're also going at the coronal plane of the natural ostium of the maxillary, or slightly forward where the attachment of the uncinate process is. So if you stay in this plane and you go superiorly parallel to the lacrimal, that's the direction you should be going. So we've seen this classification of frontal cells, which are really in agar, supra-agar cells that have had classifications for a long time. In 1994, these were described. These have evolved into a newer classification. You remember the type 1, which is above the agar nasi, the type 2, which is multiple above the agar nasi, type 3, when one extends over the orbit, in the supraorbital area, in type 4, where there's an independent one in the frontal. The thing it doesn't take into consideration is inner sinus cells that may vary in between the two frontal sinuses. Henceforth, this classification of the international classification of the frontal sinus anatomy. And you can see down below what I had just discussed, and above the new classification, you see in red, meaning the red cells here, the agar, supra-agar, the green, meaning the green cells, bulla, suprabulla. And you can see that it's more based on anatomy. You've got the agar nazi cell, the supra-agar cell or cells, and then the supra-agar, that frontal cell, which is the last cell up here that extends up into the frontal sinus, which was previously called the type 3 cell in the Kuhn classification. Then you got the bulla, suprabullar cells, and then same thing, these last suprabullar cells, particularly this one in front of the anterior ethmoid artery, may extend up into the frontal, or it may go over the orbit to either be a supraorbital ethmoid cell or a frontal or a suprabullar frontal cell. And then, of course, the last one is the frontal septal cell that we discussed, that are the inner sinus cells of the frontal. So this is, again, the trajectory in red is a trajectory that you really are in, and when you're in a coronal plane of the frontal infundibulum. Back here, notice that you're nowhere near the bulla and suprabullar cell. There's a little bit of a frontal extension of a suprabullar cell here. But for the most part, if you're going to error on staying too far anteriorly, not on staying too far posteriorly when going in the trajectory of the frontal. And it's always parallel to the nasal lacrimal convexity that's seen in yellow here. In primary cases, I think we're all aware where the frontal recess is. We just follow the uncinate process up. And we know that it's at the coronal plane of the uncinate natural ostium, and it's behind the uncinate process. We've removed the uncinate, was attached here, and you can see it's behind, it's up against the vertical lamellar middle turbinate. We've already opened the agar nazi and the type 1 cell here, or a supra-agar cell here. And notice where the red line is. The frontal recess is the posteromedial aspect of the wall of this last supra-agar cell, and it's anterior to this first suprabullar, the last suprabullar cell up here, behind which is going to be the anterior ethmoid artery. So what are the tips in optimizing outcomes in sinus surgery? Obviously, historically, we've always heard that we need to preserve mucosa when possible. Obviously, this is not possible in some cases, especially in revision cases, polyp cases, things like that. We certainly try to preserve it, but when there's irreversible changes to the mucosa, we have to do other things as well. And it may not be possible to preserve all the mucosa, particularly around the frontal infundibulum. We have to know and understand the relationship of the ethmoid cells to the frontal, as we just discussed. So we have to know how to perform a thorough ethmoidectomy and removing the patients carefully so as not to crush them up into the frontal recess or frontal infundibulum. And also understand that in some circumstances, more extensive surgery to the frontal outflow tract may be necessary to maintain patency and ultimately do what we want to do with sinus surgery, especially in polyp cases, which is to facilitate medical management, particularly topical medical management, which is really going to be the main line treatment for these patients in controlling their inflammatory disease. So type 1, we've already shown you, it's just removing the auger, supraauger, leaving the last supraauger and the last suprabular cell intact, and then basically just leaving the recess right here. This is from a cadaveric study, so you see it's dilated already. There's a probe inserted into it just to dilate it a little bit, more or less what you would do with a balloon if you were just to leave the ethmoid cells intact. This is the area you're going to go up against the vertical lamella middle turbinate behind the insertion of the unsate that I'll show you in a minute, and basically go up from a medial to lateral and supraorbital direction to go up into the frontal infundibulum that's above the dome of this last cell, which is the last supraauger cell. Again, this is a type 1, remove these cells here, but leave this last supraauger cell intact. So here's the relationship of the uncinate. The uncinate doesn't vary too much on its inferior and lateral attachments. Inferiorly, it attaches just lateral and inferior to the ostium of the natural ostium of the maxillary. Laterally, it inserts into the lacrimal groove here behind the lacrimal duct and lacrimal sac to insert, and then superiorly and laterally inserts into the floor of the agarnazi. But where it's most variable, it's this superior medial attachment, which can either insert up against the face of the last suprabular cell, or it can attach towards vertical lamella middle turbinate. Regardless where it attaches, the relationship of the frontal recess is always the same. It's in the coronal plane of the face of the inner of the face of the bulla or the uncinate edge here, and it's up against the middle turbinate. And you can see here we've removed the uncinate. This attaches to the face of the last suprabular cell here, or one of the suprabular cells, and you can see that the frontal recess is up against the vertical lamella of the middle turbinate right here, but behind the coronal plane of this insertion of the uncinate. These are different attachments, as I mentioned. Here, the uncinate attaches to the suprabular area. The uncinate attaches to the vertical lamella. Regardless, here's the asterisk where the frontal recess is, and it's always in this location at or slightly in front of the coronal plane of the face of the bulla. So sometimes you can just, this is an example of how we would use SinusAnatomy. We go behind the uncinate process in an office balloon for a very focal blockage of the right frontal under local anesthesia. We would put our probe on there and just balloon this area just to suction this area out. Now, what you would do with a balloon is you would crush the auger cells laterally to open up that frontal recess area and dilate it, which is what we're looking at right here. And of course, this is the post-op image. So when we go to type 2A frontal sinusotomy, we go to the next step. Here is where you have to remove that supraauger cell, the last one, in order to get the view of that frontal infundibulum, which is this snow cone shaped, upside down snow cone shaped area that we typically look up with to see a typical type 2A frontal sinusotomy. This is perhaps the majority of you and myself probably do this the most in a lot of cases on a routine basis, where we remove this medial wall of the supraauger cells and then continue on to remove the dome. And then you start having this wide opening looking up, and you can actually remove more of this bone of the supraauger cell to view and visualize the frontal. Notice that the anterior ethmoid artery is way back here. There's that last cell, that suprabular cell in front of it here, and another one behind it. And it's this one that's about a centimeter in anterior posterior dimensions, usually around a centimeter. So it's about a centimeter between the anterior ethmoid artery and the back wall of the frontal infundibulum in most cases. So in revision cases, we use other types of landmarks. Anytime we do revision cases anywhere in the body, whether it's otologically or rhinologically, the type of landmarks we use in revision cases are totally different than what I just told you. So what I just told you are the normal primary landmarks that are taught in most labs and cadaveric labs, but you also need to learn revision anatomy, and because you can't apply the same concepts to revision that you use for primary cases. And in the case of the frontal, we certainly already told you some of those landmarks. And one of them actually is the lacrimal. Another one is the insertion of the middle turbinate, anterior middle turbinate at the axilla area. And then more importantly, you have to understand the coronal plane in which you'll be working in as you go up in the trajectory into the frontal infundibulum, so as not to go too far posteriorly towards the skull base. So you have to stay in front of the ethmoid bulla. If this is not available, then you just have to stay parallel to the lacrimal at the coronal plane of the natural ostium of the maxillary, or slightly anterior, where the back wall of the lacrimal is. So any of these landmarks, whether it's the unsate, the ostium of the maxillary, or the back wall of the lacrimal duct, you have to use those to navigate up into the frontal infundibulum. So when we have cases like this, it's very important to understand these revision or advanced landmarks. Here I am pushing on the remnant of the middle turbinate. We've done a Draf 2A frontal sinusotomy. We see the anterior ethmoid artery here, the last suprabular cell, one up anterior, just posterior to the infundibulum here, and then the frontal type 2A, where we've removed that common wall between that last suprabular cell and the frontal. And then looking at a more complete sphenoethmoidectomy, as we would do more routinely for our polyp cases. And the goal is to open these things widely so we can then begin the real treatments, which are topically directed, different topically directed therapies. And of course, not pretty, but it's functional. The patient gets the smell back. The cavities are open. Here's the sphenoid, the frontal, the maxillary, and more importantly, able to get medications and steroids and stuff in there to control the inflammatory disease. So how about extended frontals? Then we go to the next step. We obviously, the indications for this has changed over the years. Since the 90s, when I started doing Draf 3s, we used to only use them in very reserved cases, but soon we found out that if we didn't do Draf 3s in a lot of patients, particularly with polyps, then we found that the recurrence rate was higher. And that's been subsequently observed by other experienced surgeons. So yes, we always try the minimal surgery, minimal treatments, always try medical therapy first, of course. But there are situations with advanced polyp disease, if you need exposure for CSF leak repair of the back wall of the frontal, if there are mucoceles that just have a lot of osteogenesis, where you're going to be opening, you need to open up widely. And of course, for malignancy or tumors, it's just a fact that we need that kind of exposure for anterior skull base resection. So you have to learn how to do a Draf 3, for example, before you learn how to do anterior skull base resection. And it's the same thing for other tumors as well. So in a Draf 2B, what we do is we do the same as a 2A or 2A in removing all the cells, including the supraagar cells. But now we remove this anterior portion of the vertical lamella of the middle turbinate. And you see the green area here is the part of the middle turbinate we remove that actually corresponds with the medial wall of the frontal infundibulum. It does not correspond with the skull base. The skull base is back here and corresponds with the second half of this vertical lamella of the middle turbinate, and the middle turbinate vertical lamella as well. So if you stay anteriorly and take this first quarter of the middle turbinate, what you're going to be doing is following it up to the medial wall of the frontal infundibulum. You can see that in green here is where the supraagar and agar cells run, and in red is where the bulla and suprabular cells run. So you're really staying at the agar column of cells and going straight up medially to give you this kind of view into the frontal. Here we've already completed the Draf 2B, where we've removed this little triangle of bone where the insertion of the middle turbinate, here's the cut edge of the middle turbinate here. This is where the middle turbinate was inserted here, making up the medial wall of the frontal infundibulum that's in green. The other thing that you have to learn to do these more advanced cases is you need to understand your relationship of where you are to the cribriform plate. Here I put the cribriform in white, and understand that the cribriform, where it starts here, is at the same coronal plane, whether you look with a 30-degree, 45-degree, or 70-degree telescope, it's at the same coronal plane as the back wall of the frontal infundibulum, which I've circled in green. So before we took this medial wall here and extended the frontal infundibulum medially, this is what it looked like back here. And so if you find that back wall and you draw this line and then just drop down medially and inferiorly, you're going to find on the other side of the middle turbinate where the cribriform plate starts. Now, if you're going to do these type of procedures, it's important to know that and also understand sometimes you have to elevate a little bit of this mucosa anterior to it to find your first olfactory fibrils, just to basically confirm that that's where you are. And once you confirm where you are, everything anterior to that is fair game. You can drill anything anterior to that all the way to the dermis of the nasion forward here, or the dermis of the supracanthal dermis of the nasal bones over here laterally. Or you can go medially and go towards the other side for a draft 3. So in the draft 3, this is exactly what we do. We do a draft 2B bilaterally. You can actually go from one side to the other. You don't necessarily have to do a 2B in the other side. You can just connect it by just continuing to drill or from one side to the other. And you typically do an anterosuperior septectomy, as you see here. Again, the back wall of the septectomy is anterior to the back wall of the frontal infundibulum in order to preserve the fibrils, the olfactory fibrils that are on the septum that run from the cribriform plate. So you try to make this back just like the septectomy at the back wall of the same place you would do the extended, the 2B. And again, this is just studies or several studies in the past that have been done looking at where there are olfactory fibers on the septum and the middle turbinate, superior turbinate. And a lot of these happen to be up high. You want to stay anterior to these, the back wall of the frontal when you do the septectomy over here. So you just want to stay anterior to the positive fibers here on the septum. And you want to preserve most of the superior turbinate and the vertical lamella and the posterior vertical lamella of the middle turbinate. We all have different ways of doing it. Nowadays, just about everybody does Lothrops. And we started out in the 90s using curettes before we had drills. These are cervical spine curettes. We still use them from time to time for minimal work. And we've had other drill bits from other different companies. They vary as to which ones are most aggressive. This is the Medtronic ones here. I think these are the most aggressive. This one here, the reverse cutting. But it does vary. The Olympus has one that's more like a barrel burr like this. It's most aggressive, but it does vary between companies. And so you want to follow the back. You go from one side to the other, or you can do one side, then the other, and then communicate. But the key is to find just behind the nasion, all this bone that you're going to have to drill down and have a nice wide frontal sinusotomy that's a horseshoe shape opening. And you can see here in illustrative form, you can see the horseshoe shape opening. Notice that the center of this common frontal is anterior to the cribriforms. Here's the left cribriform anteriorly, and this is the right cribriform. You can see we've done an anterosuperior we've done an anterosuperior septectomy. So what's left here is really the base of the crista galli. So if you go through this bone, this is the bone that we go through when we're doing anterior skull base resection, and we want to expose the falx cerebri on each side of the cribriform plate as we resect this whole area of the skull base. But you can see that the frontal infundibulum are actually back here at the end of the horseshoe, here and here, but the central core area of the frontal is actually anterior to that area. And I'll explain why that's important in a minute. So here's a video illustration of what we've covered so far. There's a patient who's had an ethmoidectomy, still has the type 1 or supraagar cell here, anterior ethmoid. This is the last suprabular cell anterior to the anterior ethmoid and the frontal recess. And here, again, this goes just to show you what I had covered already. We're dilating the frontal recess, which is posteral medial edge of just medial to the last supraagar cell. We remove it. In this case, we're just cutting, we dilate it and removed it with a microdebrider. This is a cadaver dissection just to show you what we do in live surgery. And then we do the convert it to a type 2A frontal sinusotomy. We can remove some more of that. So a little trick you can have that we follow with, and only works with a 70-degree telescope, is if you look laterally with a 70-degree telescope and the edge of the scope here. So at 3 o'clock, you put it at the level of the mid to anterior aspect of the maxillary ostium right here, and then you hold the camera and then rotate. So this point here goes to 12 o'clock. This will rotate it so that what you're looking at 12 o'clock here is actually the frontal infundibulum. And the reason that works is, remember that I told you that the frontal infundibulum is at the coronal plane of the natural ostium of the maxillary. So when you have an angled scope, you're able to really visualize that quite well. So we're going to do that. And if you notice, this is where we were before. Remember where we were at 12 o'clock? This is the frontal infundibulum right here. The last suprabular cell here, anterior ethmoid, back wall of the frontal infundibulum there. So the correct placement, the reason we tell residents that when we're doing sinus surgery and we're blindly trying to probe where the frontal is, yes, we try to find the axilla of the middle turbinate here, the anterior attachment. We want to put the shaft up against that middle turbinate, so it pushes the middle turbinate up against the septum. And then we're going to probe just behind the axilla. As we put the probe up, we want to angle it on the left side. This is the left side. On the left side, we want to angle it as if we're going to go over the orbit on that side. And you want to keep the shaft up against the middle turbinate septum complex there as you're doing it. And the reason we do that is because you notice as we go over the orbit, this is the direction we're going to go. We go up against the natural inclination of that frontal infundibulum and the back wall of the frontal in that area over the orbit. If you put that shaft up against the orbit and try to do the same thing, then the danger with that is that you're angling it towards the back wall of the frontal. And if you push, you end up going through this back wall of the frontal. Or if you're too low here, you go through the cribriform. So in a Draf 2B frontal sinusitis, the key here again, like all Draf 3 or 2B, is to know where the cribriform is in relationship to the back wall of the frontal infundibulum. So if you do this little exercise and you just rest the frontal shaft, as I showed you before, against the middle turbinate, but put the little ball up against the frontal infundibulum, everything anterior to that shaft is going to be removed as far as the middle turbinate is concerned. That will give you an idea that everything that the cribriform is just going to be medial to the shaft of this probe, but on the other side of this middle turbinate, down in this area somewhere. But you need to remove this whole area, including the insertion point up here, and you need to drill down the bone of the insertion point in order for you to be able to have a good visualization of that frontal sinus as you drill superiorly. So again, back wall of the frontal, this is the line of the frontal, back wall of the frontal infundibulum and where the cribriform should lie. Here in blue is the cribriform. This is the area of the middle turbinate we removed. We want to stay anterior to the blue line when we drill. We want to drill all that bone. One little trick we can do here, we've removed this portion of the middle turbinate, which again, when we do a Draf 2B, we remove this portion, which becomes the medial wall of the frontal infundibulum. And it gives you this triangular piece of bone that we typically remove and drill away when we convert a type 2A frontal sinusotomy into a type 2B up against the inner sinus septum, or the junction of the inner sinus septum with the perpendicular plate. Another exercise you can do is remove the mucosa over starting at the septal angle and all the way back just medial to insertion of the middle turbinate here. And you'll find this little groove here. This groove corresponds to the nasal branch of the anterior ethmoid artery. That's a branch of the anterior ethmoid artery as it re-enters intracranially and sends branches every direction. There's one that comes up to the nasal bones here and makes a little entrance right here. Then it goes through a little groove and then disappears into the soft tissues underneath the nasal bones. So sometimes it'll have this little groove or trench here. Sometimes you just see the artery entering right here in this little hole. Regardless, if you identify that artery and just cauterize it, we've done this study on cadavers, and we found that it's about 2 millimeters from the first olfactory fibrils, as you can see 1 and 2 here of the olfactory fibrils, which are the anterior cribriform plate that lies at the level of the frontal infundibulum. Other people, if they can't find the artery, then they just go straight to the fibrils and try to find them. And the reason we do this is once we find these structures, we we know that all this bone, starting medial, anterior, and lateral, can be removed safely without any problems. Oops, sorry, went back. One second, I'm a little behind here. All right, so we're going to convert the Draft 2B now into a Draft 3. And the way you do it is just after you've determined where it's safe to remove the bone, then you can go ahead and start drilling once you've identified the first olfactory fillet or the nasal branch of the anterior ethmoid artery. Then you can start drilling all this green area. You can start medially, you can start anteriorly or laterally, but it starts converting this into Draft 2B. And then as we go across the midline, we'll convert it to a Draft 3 frontal sinusotomy. So here we're drilling progressively. We see a little hole here. We're going to the other frontal sinus. That's the inner sinus septum. And then we just progressively just enlarge it. Remember, we do the septectomy. And then we have the final look of the frontal, the common frontal, typical horseshoe shape of common frontal that we see here and that I've showed you before. And the good thing is you can look supraorbitally. Once you're on one side, you can look tangentially to the other side to really look into this supraorbital area to really get a good glimpse of that area in case there's pathology here. So this is just an article from PJ Warmold, who and others have pretty much have learned through the years that this is in fact the case, that there is a subgroup of patients with polyps, particularly with severe disease and with associated with a triad of asthma that require extended frontal sinusotomies, if anything, just so that we can control their disease or inflammatory disease. And we're finding that as primary cases, we're in those in areas like Miami, I'm sure in the Middle East too, where they're indigenous for endemic for nasal polyp disease, that this is the case. And again, you get cases like these where you have typical recurrent disease, and you can see the very typical findings of some edema, but then you see the polypoid changes. Where do they occur? They occur in the anterior ethmoid cavity. We've done a good ethmoidectomy, but you see they're starting to come back in the anterior ethmoid cavity and superiorly. And you have this glue, and a lot of this, it's the cytokines that are building up in the frontals that are coming down and raining down on the rest of these sinuses, making it miserable. You can see that the right side is the same thing. You can see the polypoid changes are mainly anteriorly. So in this case, we do a frontal Lothrop, mainly to expose things widely and to, I'll go quickly here, and to open things up. This is an older video before we were using drills, but just to open things up widely, so then we can begin the treatments, the topical treatments. Sometimes we'll put silastic in those areas if we've done an extended amount of drilling. This does not reduce the stenosis rate looking at 6 months, but it does make it easier to maintain these cavities post-op. Now we have newer biologicals that we can put in there, like with steroids and stuff that work just as well. Of course, the post-op treatment. We've published a number of times. This is one from actually from 2006. We had a previous study in the 90s looking at our experience with Lothrops, but pretty much our experience has not changed. We see if you say patent is more than 50% of the original patency of the intraoperative patency of the Lothrop, and stenotic is less than 50% but still open, then about 94% of the patients maintain some sort of patency, even if it's a tiny hole, and about 6 to 10% are closed completely. Surprisingly, many of these patients don't need further surgery because they're not symptomatic. So you have to follow their symptoms to determine whether you need to revise the Lothrops. We also found that the revision Lothrops are more successful in maintaining patency than if they close than if you were to do them again. We also found that when we stented these patients, again, they didn't really change the stenotic or closed rates. They just really just helped in the debridements and the cleaning and getting medications in there. So here's a patient who's 61 years old, who had bouts of forehead pain associated with purulent rhinorrhea, at least 2 bouts of periorbital cellulitis on the right side. Each bout improves with antibiotics. They are culture directed. Of interest, she's had multiple facial traumas with open reduction and multiple fractures 20 years prior. So we see this, we see all the metal she's got in her in this area. And then the question is, how do you approach this? Do you approach, I guess when I was a resident, we would have to do a bicoronal and do a osteoplastic flap and do an obliteration in these cases. And then again, you see all this crushed tissue here, and you want to get up into the frontal infundibulum here, but you see these wires and all these things here. So I frequently present cases like this at panels and see what everybody says, and there's a mixed reaction. A lot of it has to do with the experience with doing things endoscopically and the comfort level. But this was approached endoscopically by us. Again, you can see the hardware that this patient has all along the nasal bones here. It's also got erosion or mucocele here anteriorly, perhaps a pus puffy tumor starting to develop. So in this kind of case, we decided to stay in the midline, first of all, and this is why you need to learn midline approaches into it. But we want to stay in the midline to enter this area, midline, and then open from there. So we want to open everything in the midline and work our way out. We just kind of pull our wires one by one, cut them. The microdebrider, actually, the blade was sharp enough to, and the burr was sharp enough to deal with this. And we just progressively open things up until we get things opened. And what we did was basically an extended Draf 2B. We really didn't open the left frontal infundibulum. We just opened things up from right to left, from the midline, just enough to keep things open. There's your completed Draf 2B right here, as you can see here. And we were able to get the mucus out and drain that mucocele. And this is it. Post-op, about 6 months later, it's still patent on that side, and the patient's been doing quite well. And here it is, post-op CT scan. Notice we really just did like a Draf 2B, extending it here, but not really taking down the inner sinus septum, but doing the septectomy with the Draf 2B. So different modifications you have to learn how to do depending on the individual case. Another patient that, again, as a resident, I would have done a bicoronal, and this is a pus puffy tumor, as you all can see, with erosion of the anterior table. And in these type of cases, again, we just open it up. We did a Lothrop on this patient. We irrigated the sinus. We took out the pus, and we left the silastic in there just to, this is a post-op, in order to maintain debridement ability and irrigation ability. And this is, again, the post-op on this patient. Again, this is something that I would have done a bicoronal. And when 30 years ago, 20 years ago, we would have done that. And nowadays, don't need to. So what are the special considerations in the remaining time that we have to do when we do extended frontal sinusotomies? We find that it's safer to perform a contralateral or transeptal midline approach when more traditional frontal or rhesus approach may be obliterated with fibrosis or osteogenesis. Sometimes we also may have to combine it with external approaches, albeit it may be more limited incisions. You still may have to do what we call a multi-port approach into the frontal sinus. And this is what we mean by external approaches. So this is one of my past fellows, Dr. Eloy, who has published considerably on the topic and other topics having to do with skull base. And this is one where he really wasn't so much to create new classifications on top of the Draf, but just to illustrate that there are many ways to modify it and be able to communicate with each other when we tell each other what we did or we publish. This is more for classification for when we do publish, so we can be talking the same language. And of course, he added this Draf from the Tract 2B. He added a C, a D, E, and an F. And in the C was something like this, where you do a temporary septal flap, where you would allow you to go from a contralateral approach to get into these supraorbital lesions, give you a better tangential look at drilling or taking out the medial wall of these lesions, rather than doing it ipsilaterally like you see in the red line. He called that a 3C. And then a 3D, where you would actually do a Lothrop from right to left, kind of like I showed you in the cadaveric example in the video. You would go, in that case, it was left to right. In this case, it was right to left, but preserving this anterior ethmoid area that's already been obliterated by fat in order to decompress this frontal into the right side and then down into the right side drainage area. Sometimes you can do, you remove a tumor like this, you do a Lothrop from left to right, like the video, but preserving the frontal recess on the right and all the ethmoids on the right, and certainly accomplish the task. And sometimes you can do a purely midline approach, where you preserve both frontal recesses and anterior ethmoids, but go straight up the septum. The Aussies call these the outside in approach. Since the 90s, there have been many names since we've been doing these. When Don Lanza had done these in the 90s, he coined them a transeptal approach. We've called it midline approach into the frontal. Either way, as long as you know we're speaking the same language. So when you're doing this midline or transeptal or outside in approach, what you're doing is you're targeting this red area of the frontal, this common area of the Lothrop procedure. Notice that the frontal infundibulum is way back here at the end of the horseshoe, okay? So, and you're gonna stay anterior to the cribiform. And where you're gonna go is along this big red arrow up here. Notice we're anterior to the, or at the attachment of the middle turbinate. We're not in the green arrow, which is the direct, the coronal plane of the frontal recess that I had shown you previously. And again, I showed you this before. We want to stay in this area of the green zone, not in the red zone. We want to go in this area. We want to identify the cribiform plate and its fibrils and the anterior nasal branch of the anterior ethmoid artery, and start drilling in the midline right here in front of the cribiform, but in the midline to enter that central core, enter central core of the common frontal. Again, just to point out, this is the anterior, the nasal branch of the anterior ethmoid artery is this little artery right here that we see from the anterior ethmoid, okay? And you can see it right here going through its trench, and of course 2 millimeters in front of the olfactory fibrils. So we identify these structures early on in order to know where to start drilling in the midline. So here's an example. You've got a mucocele, obviously, of the frontal sinus, of the inner sinus cell. Really, all the sinuses are normal. The frontal recesses are functioning well. So all we did here was, because of the pain in the midline, we just took down the mucosa from the septal angle to identify the anterior ethmoid artery. We're just, you can do this starting at the septal angle, anterior to the attachment of the middle turbinate, and then work your way from front to back to expose the artery, which is, you'll see the little trench right here. This is the trench, and this is the artery right here, re-entering, okay? Once you identify that, anything anterior to that artery is fair game. You can start drilling this whole area, and you'll enter that central core of the frontal sinus. Here's the artery again. So you could start drilling medially, anterior to that, and enter the mucocele. And then from there, you can work from medial to lateral to enlarge that opening. You can take more septum out and make as large an opening as you want to accomplish this. So that's a transseptal approach. And again, you know, there are situations like this. There's a patient who had prior decompression of Graves. You needed to get into this area. So we enter from right to left to take down the inner sinus septum, communicate both frontals to create this kind of an opening. This is an example of that. Another patient with bilateral decompressions, recurring cellulitis, orbital cellulitis, and had these little areas here that corresponds actually to the old supraauger frontal infundibulum area. Patient had prior obliteration of the frontal higher up, and multiple years history of pain, pressure. When you do an MRI, just to confirm, you can see that this is not fat. This is all mucus and trapped in that area, little mucocele. So something like that, we went in the midline, transeptally, and we would go up Notice that the middle turbinate's still intact here. We're anterior to the middle turbinate. Transeptally, we enter this area and we open and drill this area up until we find the back wall of the frontal. We find the fibrosis from the previous obliteration procedure, and we widely open this up without having to touch the middle turbinates or the medial orbital walls in the area. So when is a transnasal approach not sufficient by itself? Obviously, when you get these well-pneumatized areas high up or laterally over the orbit, and you have lesions in these areas, it's pretty tough to only do it endoscopically, although we virtually start endoscopically for exposure in the midline on most of them. And there are different ways to do it. And this is actually from my book. A lot of the figures in this presentation are actually from my book with the videos as well, if anybody's interested, and I'll show you that at the end. And you can make limited incisions either on transverse skin creases, on the medial or lateral eyebrow, to enter and do multi-port procedures where you would do a Lothrop or a 2B endoscopically, but then make these little wide trephinations in the frontal sinus in order to get the drill and telescopes and to work from both directions. And at the end, we leave a titanium plate to cover the hole. This hole here just needs to be large enough so you can simultaneously put a scope and a drill bit into that area. It could be medial over here on the frontal sinus, or it could be lateral in the frontal, depending where you make the incision. You could also go transorbitally and develop another port. If you're not familiar how to go transorbitally, I would suggest you do it in the cadaveric labs, but you would do a blepharoplasty type of incision. You find, you stay up and enter to preceptal and enter the floor of the frontal, and then you'll be able to enter the frontal or even the anterior skull base supraorbitally in this area. So those are another approach. As an example, here's one where we did a combined Lothrop with a transforehead approach through a multi-port, and you can see the left proptosis. And surprisingly, this guy, 56 years old, wasn't complaining of proptosis. He was just complaining that he couldn't clear when he was diving. And then we did a scan, and we saw the proptosis, and this is what came out. So we would basically, in a case like this, we would start out with the Lothrop and take out and drill out as much of this from the midline as possible in pieces. And then we would go through where it had eroded the anterior table. This is a little bigger incision than I would normally do, but this is the area that had been eroded already by the tumor and had to go anyway. So we had a nice big opening here, and we were able to work on both sides. Here's in yellow is the dura, and you can see the mucosa being stripped. And then we work from above and below, removing the remaining fragments, drilling it. And he happened to have nice skin folds, nice creases in the forehead, otherwise known as wrinkles. And we were able to accomplish that in a very cosmetically pleasing way. So when we finish, we can work from below. You have I'm above, my fellows from below. We're just kind of teasing away and irrigating, getting all the bone dust out of there, and remaining fragments of that tumor from the orbit and from the intracranial cavity. See all the fragments. And this is the post-op. In this case, we left a larger than normal titanium plate to cover it, but he did quite well post-op. Here he is post-op. You can see where the incision was right up here. But was able to, this is about 6 months later. And then you may, like I said, you may have to go transorbitally. And here's a case of a patient who has failed multiple frontal Lothrops, has redeveloped osteogenesis, continues to develop these supraorbital, posterior supraorbital mucoceles. And what we want to do is do a focal obliteration transorbitally. We would enter and remove all this mucosa in here, as you can see on the video, and then drill it all down with a diamond burr and then fill it with fat. This is the horizontal component of the frontal, the supraorbital component of these cells that is hard to reach transnasally and hard to obliterate. So we went transorbitally to do that. We also had to do the vertical component of the frontal on this side. So we went through a transfrontal, as you saw previously, we make an incision, a much smaller incision. We do the trephination, we drill out all the mucosa inside that vertical component of the frontal, make sure everything's out. And then we fill it with fat, both the horizontal and the vertical component. And we basically do a focal endoscopic obliteration of that sinus. You can see what he would complain of, cellulitis, every few months, and that's why we had to do that. And it's only, surprisingly, as much as he had this much on the left side, to date, his only complaint has been the right side. And that's been resolved with the surgery. You see the incisions there. And this is about 20 months later. He's been doing quite well. And you barely can't even see the incisions there in the forehead. And then finally, this is kind of the ultimate use of the Lothrop procedure, which is when you do anterior skull base surgery. Obviously, this is a topic for another discussion, but it's crucial that if you're going to do skull base surgery, you have to learn not just extended frontal procedures, but you have to learn extended maxillaries, extended sphenoids, learn how to decompress the orbit, all that stuff, because that's all part of the foundations. It lays the foundations, our abilities to expose these areas for tumors and to make sure we have clear margins. And of course, we have our own way of repairing these defects. Everybody's got their own way. But again, this is kind of another usage for the extended procedures. So I thank you. These are my connection. If anybody has questions on Facebook or Instagram, Cassiano Rhinology, this is my email. This is the book that you can get through tima.com, and it's got all the illustrations, videos, and everything that I covered today, if anybody's interested. And I thank you again for the opportunity to speak to you. If any questions, anybody can bring it up.
Thank you very much, Dr. Cassiano. Very nice talk. I just have a question myself. We had Richard Harvey with us a few weeks ago, and he likes to use a 0 degree scope to get like a really direct access, and he thinks that this provides for a better access in terms of administering medication later on locally and stuff. What's your thoughts about that?
Yeah, I think if you compare the extent of removal, it probably doesn't, as long as you adhere to what we talked about and remove the bone that we're talking about anteriorly and laterally. I'm not sure that having a 0 or 30, I found that I could do it with a 30 degree. The 0 degree is okay if that's what you're familiar with. We have a joke in the United States where we say that you can tell somebody's been trained as a head neck surgeon versus a rhinologist. And that's by the scope they use, because the rhinologists tend to use more of the angled scopes and the head and neck surgeons more of the 0 degree scopes. But that's okay, whatever they need to use. And it's true, when you use 0, you do have to do more exposure, because you want to get around the angles. You want to do more exposure to be able to see. So it kind of forces you to do more exposure. But you can do that as well. I mean, with a little experience and learning how much you need to do, you can do it. We basically palpate the nasion here and the nasal bone here, and we want to see dermis. Even though we don't expose it all, we want to know the level of dermis. That's our lateral and anterior exposure. And then the posterior exposure is the cribriform, like I showed you. You can't go anywhere else. You either go into the dermis or you go into skull base.
So using the drill from the inside and palpating the outside, the skin on the outside? Okay. And what else? There's actually quite a few questions on the chat line. Can I ask you to take a look?
Yeah, I'm looking at it right now. Let me start from the top. Let's see. I see a lot of good evenings. Okay. If a lesion situated at the lateralmost part of the frontal sinus, how to deal with endoscopic. And I think I covered that and towards the end of my talk. I would do either transorbital or do a lateral brow incision or both, and be able to work simultaneously through multiple ports. I mean, we're not the first one to describe multiple ports. The laparoscopic surgeons have been doing it for ages. So creating multiple ports for different access is nothing new. I mean, the nostrils aren't the only port that we go through. We can go through other ports too. How can you fix silastic after frontal surgery? How long? Well, the stent that I showed you is rolled up in the size of that horseshoe shape, and the center core of that stent lies on top of the septectomy. So it doesn't go on either side. It just rests right there. Okay, that's how that one is. I know others have different ways of fixating, but it's basically the same thing. It sits kind of on the midline upper part of the septum, or you've done the septectomy. In cases of severe disease, how easily can olfactory fibroforamina be? You should be able to identify the olfactory villi every time. The one that's harder to find is that nasal branch, where you've had a lot of scarring up there. So your fallback is to find the villi. But the villi, all you need to do is practice it a few times in the cadaver lab, and you'll find it. Once you've done it a couple times, it becomes pretty second nature. If the lesion is in the lateral part of the frontal and medially is thick bone, which obstructs the drainage system, what will your approach in that case? We would do the same thing. The only difference is, in this case, we would do for where there's a lot of osteogenesis, the midline, we would drill more in the midline and do more of a transeptal approach, a midline, outside-in approach, whatever you want to call it. Identify the villi, go in the midline, then work out. Okay, if we can't with a lot of assurance know that we're at the level of a type 2A, or we can't do a type 2A to find the back wall of the frontal infundibulum. So we can't go from a lateral to medial approach. We'll go from a medial to lateral, always from known to unknown. And if for some reason you can't do that because there's fat or something like we saw in the Graves case, then go to the opposite side and then go from the normal side to the abnormal side. And that's not just with the frontal. We do it with the sphenoid too. Okay.
How do you position the patient? Like how much extension?
No extension, just normal positioning. There's no extension of the head or anything. You don't need to when you use angle scope. You may have to with a 0 degree, but you don't need to extend their neck or anything, just in a very normal, comfortable, which is a good point, because you have older patients with cervical spine disease, you don't want to be manipulating their neck every direction. Do you use computer-assisted navigation? No, we have some computer navigation, but we don't use it for frontal disease. We do it on purpose, and if anything, just for training purposes for our fellows and our residents, so they learn anatomy. They don't become totally dependent on navigation. And once you're taught this advanced, I think it's like anything else. Once you learn how to use advanced anatomy, advanced type of landmarks, that it becomes the second nature, and many times you don't even need it. But
you don't use navigation, really, huh?
No, we don't use navigation even for anterior skull base resection. We know where the brain is. We can find the brain very quickly. We do use it when we're in the middle and posterior cranial fossa. Anytime we're around the carotid artery, we not only use navigation, we use endotopular, because we don't even trust the navigation, to tell you the truth. When we're drilling around the carotid, we don't trust it. I mean, you may be off for 2 or 3 2 millimeters is a lot for when you're drilling around the carotid. And so we use the endodoppler quite a bit in those cases. Let's see, anything else? For a lateral recess or posterior wall defect with CSF rhodia, what is the extent of exposure? In the case like that, it depends how far laterally in the back wall of the frontal it is, but a lot of them are more midline or off the midline. And in those, we just do a Lothra to gain access, be able to work through both sides of the nose, elevate the dura. It's a different talk about showing you how we repair it, but basically that's how we do it. And that's it. Oh, here, how to deal with frontal CSF from the inner sinus cell. Same thing. Same thing. We go through a Lothra.
Thank you very, very much. Really, very nice lecture. Enjoyed having you. I will send you the link to the recording.
Thank you. Yeah, I can share it with my residents and fellows that missed this today. So,
are you keeping safe? How is Miami? A lot of cases, huh?
Yeah. We're still doing elective outpatient surgeries. They've closed down all our elective inpatient surgeries for obvious reasons. They want to conserve the rooms. Our residents have been reassigned, some of the more junior residents reassigned to the COVID floors. Imagine being an ENT and having to work the COVID floors as a medical doctor.
Yeah, well, thank you again. Huh? Really enjoyed having you with us.
Yes, enjoyed it. Hopefully, stay safe.
All right, you take care.
Take care. Bye-bye.
So take care, guys. I'll see you soon.